I'm Chris Lieu. I'm a GI medical oncologist at the University of Colorado Cancer Center. So the liver is the most common site of metastasis for colorectal cancer. And though metastatic disease often precludes surgical resection, it is also known that liver-directed therapy can increase overall survival when patients with colorectal cancer are chosen carefully. So in patients with oligometastatic disease, various methods of liver-directed therapy can be used to treat tumors. And the key decision points for these patients include which patients are the best candidates for liver-directed therapy, what is the appropriate therapy to use, and what is the best sequencing of therapy, especially if a primary tumor is still in place, either in the colon or the rectum. So liver-directed therapy encompasses several different modalities. That includes surgery, radiation, and interventional radiology procedures. So these IR procedures can include ablation, they can include Y90, also known as SIRT, and we'll talk a little bit more about that later. And they can include embolization with or without chemotherapy. Now, the most common modality of liver-directed therapy is surgery for oligometastatic disease. So for patients with metastatic CRC with limited liver metastases, surgical resection can be considered, particularly if there's a solitary lesion or if you have tumors on the same lobe of the liver. So here, the use of multidisciplinary management for these patients is critical, as oftentimes patients will receive chemotherapy either prior to resection or as part of a staged resection of the primary tumor and the liver metastases. So the use of perioperative chemotherapy is somewhat controversial, and there are a lot of studies investigating the use of perioperative or adjuvant therapy, and a lot of these studies show a true progression-free survival, but oftentimes these studies also show no statistically significant overall survival benefit of perioperative chemotherapy. So the most famous of these studies is the EORTC 40983 study. And in that study, they compared perioperative FOLFOX with surgery versus surgery alone. And in that study, the disease-free survival was 20 months with perioperative FOLFOX versus just 12.5 months for surgery alone. But in that same study, there's no statistically significant difference in overall survival. It was 61 months versus 54 months, trending towards favoring chemotherapy, but again, not statistically significant. More recently, at the 2020 ASCO virtual meeting, the JCOG 0603 study again showed no survival benefit with adjuvant FOLFOX versus surgery alone. However, chemotherapy can be used as a test of biology to improve the chances of a complete resection for patients with borderline resectable disease, or as an intermediary treatment, especially if the primary needs to be resected first, and then the patient needs to recover prior to a liver surgery, or if the liver mets are resected, followed by the primary tumor resection. For patients who are not surgical resection candidates, there are other liver-directed therapies that may help with disease control. For small lesions not amenable to resection, you can ablate a tumor, right? If that tumor is less than 2 centimeters with interventional radiology. Liver radiation has traditionally not been used, but stereotactic body radiation therapy, or SBRT, is another modality of radiation that can treat oligometastatic liver disease. And finally, a combined analysis of 3 large frontline trials investigating the addition of selective internal radiotherapy, or Y90 or SIRT, to frontline FOLFOX chemotherapy for patients with metastatic colorectal cancer with liver-only or liver-dominant disease. All of those studies failed to improve overall survival compared to FOLFOX alone. Therefore, its use in patients with liver-only or liver-dominant metastatic disease should be used only really in select cases, and they shouldn't be considered standard of care. But really, the key to liver-directed therapy for colorectal cancer is really just a robust multidisciplinary discussion, as each patient is going to be unique with unique comorbidities, all which need to be considered prior to starting any therapy.